Hi, my name is Yanis Dahel. I'm a French gastroenterologist and I worked in Dijon University Hospital, and I'm the co-author of the article selected by GIE, and thank you for that. This article is titled Adherence to Post-Polypectomy Guideline after high-risk polyp removal. I want to thank Professor Manfredi, Dr. Dogan, Dr. Côté, Mr. Buisson and Mr. Dasseux for their huge help. That was a fantastic collaboration and I'm very grateful. As you know, colorectal adenocarcinoma is a major cause of cancer-related death. To reduce it, we've got mainly the colonoscopy that able to classify patients as low or high risk categories depending size, number and pathology of resected polyp. Then from this category we establish delays of control colonoscopy. In France we had an update in 2012 concerning risk category, and then 2 years later French Society of Digestive Endoscopy published quality criteria for colonoscopy report supposed to improve patient adherence to follow-up colonoscopy by giving them clear written instruction. We already knew that the absence of follow-up after adenoma removal was prohibitive, and we ask ourselves, we have clear guidelines concerning the follow-up delay and the way to inform our patient. It seems simple to apply in clinical practice, but was it correctly done? And in 2018 we started our work in collaboration with the Registry of Colorectal Polyp of Côte d'Or Department. This is the oldest registry. All polyps removed since 1976 in this area are recorded, and because this is a well-defined population, we can extrapolate all the results to the entire French territory. We collected all data concerning patients with high-risk polyps removed endoscopically between 2014 and 2015, and we focused on the surveillance delay given by doctors, in which report it was, and if patient had the control. And we learned some interesting things. First of all, the adherence to follow-up guideline was poor, with only 45%. Despite this population is known to be at high risk for colorectal cancer. When instructions were not appropriate, intervals were mainly longer than shorter. In a recent meta-analysis published in 2019, adherence to guideline was low as well, with 55% in a North American high-risk group. We had a look on some detail. Among our population, only 85% had written instruction, particularly among patients with insufficient bowel preparation. Only 1 in 4 was given appropriate instructions. Other important figure of this study is that only 40% of our population had the control colonoscopy, which is very low, and we're talking about high-risk polyps. But the good news is that when a patient had an instruction and underwent the control colonoscopy, they had it at the stipulated delay in 85%. So to sum up, this study concerned only patients after high-risk polyp removal. They did not have instruction in 15% of cases. Follow-up instructions were correct in 40% of cases, and when patients had control colonoscopy, they mainly underwent it at the delay stipulated in a written report. So our study suggests that we have several simple ways to improve our colorectal cancer prevention among these patients: better knowledge of our guideline and giving written instruction. This is costless and it seems easy to apply. The next step could be a new study few years later to see if training and congress organized by our national society improve adherence to guidelines.